Okay, so I'm going to start by carrying out a thorough A to E assessment of Jasmine. So firstly, I'm going to start by assessing her airway. At this point, I'm going to listen to and auscultate her chest. Here I'm listening for any stridor, wheeze, secretions, etc. Ideally, I would like to hear equal air entry on both sides, but from looking at Jasmine's case study, it states that she has been admitted for a wheezy episode, so it's likely that I would hear wheeze when listening to her. Okay, so I'd also like to be prepared for any sort of deterioration of Jasmine. So at her bedside, I'm going to check that I've got working oxygen and suction, and also an appropriate sized ambibag, mask and Goodell. I'll ensure that the face mask has a good seal around her nose and mouth, and I will measure the Goodell from the centre of any incisors to the angle of her mandible as per APLS guidelines. I'd also like to make sure I was aware of where the crash trolley was located. I'd encourage Jasmine to sit in an upright position to help with their airway, but often children with a wheeze will find a position that is most comfortable for them. If Jasmine was to deteriorate and no longer be able to protect her own airway, as she is 9 years old, I would use the head tilt chin lift manoeuvre to open her airway. Next, I'm going to move on to assessing her breathing. I'm going to count Jasmine's respiratory rate over 1 minute and look at her work breathing. In the case study, it states that her respiratory rate is 32. The ALSG guidelines state that the normal range for her age group is 15 to 25, so her respiratory rate is higher than what I would like it to be. It also states that she has subcostal recession, so I'd like to thoroughly assess her work of breathing. With regards to monitoring, I would like some continuous SAT monitoring on her. Here I can see that her SATs are 90% in 1 litre of nasal cannula oxygen. Therefore, I'd like to give Jasmine more oxygen, as I'd like her saturations to be at least 95% as per BTS Acute Asthma Guidelines 2019. You can only deliver up to 2 litres of nasal cannula oxygen, so because of this and her saturations being 90%, I'm going to put her into 15 litres of oxygen via a non-rebreathe mask and ensure that the mask was misting. I would then go back to reassess as to whether this has improved her saturations. If there was no improvement in 15 litres of oxygen, I would want to get an immediate medical review. I would refer her using the SBAR tool, clearly stating my concerns and my recommendations. In the case study, it states that she is also on 1 hourly salbutamol nebulisers, so I'd check if she had been written up for any PRN salbutamol nebulisers. Moving on to C, Jasmine's heart rate is 125, which is elevated for her age group, but this is likely due to her increased work of breathing and her being on salbutamol. I'd like to attach some continuous ECG monitoring and look for sinus rhythm. Her blood pressure states that it is within normal limits. I'd like to look at her central and peripheral capillary refill time, and I'd like this to be under 2 seconds. Next, I'd move on to doing a blood gas to assess her from a respiratory point of view. While taking this gas, I'd like to send off some U's and E's and a full blood count. A side effect of salbutamol is it can lead to a drop in your potassium levels, so the gas will be able to give us an indication of this before the formal bloods were reported. I'd also like to know if she'd been passing urine, as she has a high respiratory rate and this can cause dehydration. As a quick assessment of disability, I would use the AVPU scale. According to the case study, she is alert but struggling to talk, therefore I would grade her an A but have a low threshold to reassess or perform a more formal GCS. I find it worrying that she's only talking in 2 to 3 words due to her breathing. This is something that I will reassess now that she is on more oxygen. During my D assessment, I will make sure that she is moving all 4 limbs, check her pupils as I want them equal and reactive to light. I would ask her for a pain score using the appropriate tool. In this case, due to her age, I'm going to use the numerical rating score. I'm now going to move on to E. Here I'm going to check her temperature. I would now also do a full top to toe assessment, looking to see if any rashes were visible. Due to her condition, I would like to ensure that she has IV access, ideally 2 modes of IV access, one for infusions and one for drugs. If bloods were successful with the cap gas, these would not need to be repeated. From a fluid point of view, I would recommend that Jasmine stay nil by mouth at present due to her work of breathing and low saturations. So I would put her in 100% maintenance, start her on 100% maintenance of either 0.9 saline and 5% dextrose and 40 millimoles of potassium per litre, or Plasmolite 148 and 5% dextrose and 40 millimoles of potassium per litre. Salbutamol, as I mentioned earlier, will drop potassium, so hopefully the potassium in the fluid would aid to keep it at a normal level. When Jasmine had her blood gas, I will ensure that a drop was also taken to check her BM. When using the gas machine, it does give out a BM result, but the gold standard is to use the BM machine, so I'd ensure this would be carried out. Looking at treatment options for Jasmine, due to her oxygen requirement, she could be considered for humidified oxygen or high flow oxygen. Initially, we would start her on 15 litres via a non-breathe face mask as per BTS asthma guidelines. We could then consider moving her to high flow, initially starting at 2 to 3 mils per kilo as per SDH guidelines, as this would give her support and also ensure that the oxygen she was receiving was humidified. This gives the benefit of stopping the nasal cavity and upper airway from drying out, therefore making it more comfortable for the patient to cough and move any secretions. This recommendation comes from the World Health Organization Oxygen Therapy in Children, 2016. As mentioned earlier, the case study states that she is now on 1 hourly nebs, so increasing the frequency of these could be considered. We could also look at giving a magnesium nebulizer or IV, depending on what she had already been given in ED or previously earlier in the day. IV salbutamol or aminophylline could also be considered as per acute asthma and viral wheeze SDH guidelines. No good evidence exists for whether salbutamol or aminophylline is more effective. Aminophylline has a narrow therapeutic window, therefore blood levels are needed because there's a greater risk of toxicity. In severe asthma, inhalation of salbutamol may not have been effective because of the patient's inability to breathe enough.
2 minutes left.
Thank you. Enough therapeutic agent to get to the lungs. So overall, as I'm doing my A to E assessment, every time I do an intervention, I'll make sure that I will go back to A and reassess my patient.